Hello everyone. Today we will learn about the cardiac outpouchings, the normal variants and the pathological conditions at the CT and the MR. So let us learn first what is cardiac outpouching. So basically a cardiac pouch or outpouching, it is a contrast material or blood filled space that is arising from and contiguous with the cardiac chambers. Now the cardiac outpouching can arise from right atrium, left atrium, ventricles, interatrial septum and interventricular septum. We will learn about this cardiac outpouching one by one. So let us start with the right atrium outpouching. So the outpouching of right atrium can be divided into aneurysm, pseudoaneurysm, Subthebesian pouch and the hernia. Let us firstly discuss about the aneurysm. It can arise from any location, including the right atrial appendage. It can have normal contractility. It can be akinetic or dyskinetic and can have variable neck and body size. Again, the pseudoaneurysm can arise from any location, including the right atrial appendage. Sometimes we can see defect or tear in the right atrium wall, and it can be akinetic, dyskinetic with variable neck and body size. Now the subthebesian pouch, it is inferior to the coronary sinus ostium between the IVC junction and the tricuspid wall. It has variable contractility with variable neck and body size. The fourth one is hernia. It can arise from any location. It is basically the protrusion between areas of pericardial calcification or thickening, or either through a pericardial defect. We will learn all the entities with the images. Now firstly, the right atrium aneurysm and the pseudoaneurysm. So right atrium aneurysm are the most common congenital malformation of the right atrium, but they are rare. And the right atrium pseudoaneurysm, they are even more rare. So basically there are two etiologies for the right atrium pseudoaneurysm: trauma, which can be iatrogenic, and the second one is malignancy. So let us suppose if we discovered the right atrium pseudoaneurysm incidentally and there is no history of any trauma, then we should keep a high suspicion for associated malignancy. Now this is the first image. We are learning about right atrium aneurysm. Here in the first image we can see on the left hand side there is this focal outpouching that is arising from right atrium appendage, RAA. Now this patient was followed, and after 1 year, let us focus on the second image. After 1 year, this is the coronal image of the MR, and we have now seen that there is presence of this filling defect in this outpouching, that is the aneurysm. That is, thrombosis has developed in this outpouching. Importance of thrombosis is that now it is in indication for aneurysm resection. So this is example of right atrium aneurysm. Now treatment of right atrium aneurysm. Due to rarity of these entities, no specific treatment strategy is devised. However, usually excision is generally preferred if there is coexisting thrombus formation, arrhythmia, major dilatation or cardiac chamber compression. And if the individual is asymptomatic, the treatment is again controversial. However, some prescribe oral anticoagulants and antiarrhythmic medication. Now these aneurysm can enlarge over time, and some say we can perform the serial imaging follow-up. Now the next entity is the Subthebesian pouch. It is known as the sinus of Keith or the subeustachian sinus. Now this area has a special arrangement of the muscle fibers which gives it the pouch-like appearance. Thus in normal individual also we can have this Subthebesian pouch. It is of low clinical significance except in cases of arrhythmia. That is, it can sometimes be the cause of arrhythmia due to its spatial arrangement of the muscle fibers. But even in such cases, no specific treatment is advised. Now, if the pouch is large, for which no objective criteria is defined, we need to keep in mind that there can be difficulty in the atrial fibrillation ablation procedures. Hence, we need to mention if the pouch is large in our reports. Now, let us see the image of subthebesian pouch. In the first image, we can see this is the right atrium and this is the right ventricle. Here we can see this is the outpouching that is arising from the inferomedial wall of the right atrium. And the second image we can see it is located near the coronary sinus. So we have learned in the table that subthebesian pouch is located between the tricuspid valve and near the coronary sinus. So this is an example of subthebesian pouch. Now let us see the outpouching from the left atrium. We have completed the right atrium. The second outpouchings are from left atrium. We will divide them into again 4: accessory appendage, diverticula, aneurysm and the hernia. So let us learn about the common location of this outpouching. The most common location of accessory appendage is the inferior posterior wall. For the diverticulum, it is supero-anterior wall. For the aneurysm, it can either be posterior and inferior wall or can be left atrial appendage. Hernia can arise from any location. Now the origin: accessory appendage from primitive left atrium, diverticulum from common pulmonary vein, and aneurysm and hernia can arise from any part. So the accessory appendage and diverticula, they are small and contractile, that is less than 1 centimeter, while the aneurysm, they are generally non-contractile and large, that is more than 1 centimeter. Now coming on the walls, the first one, accessory appendage, it is hyperlobulated, that is had lobulated walls, while the diverticula and the aneurysm, they have smooth wall. Now coming on the neck, the accessory appendage has narrow neck, while the diverticulum has wide neck, and the aneurysm can either have wide neck or the narrow neck. Hernia is again same as that of right atrium, that is basically protrusion between areas of pericardial calcification or thickening or through a pericardial defect. Now let us see example of left atrium diverticulum. Here we can see this is the left atrium and this is the focal outpouching. Firstly, we see there is this wide neck and the walls are smooth. Okay, the walls are smooth and the wall most common location is the superior anterior wall. So this is example of left atrium diverticula. Okay. Now let us see the accessory appendage. Here we can see this is the left atrium and here we can see there is focal outpouching. Now it has narrow neck and the walls are lobulated. So this is example of accessory appendage, that is has narrow neck and lobulated margins. In the first example, we can see it is arising from the anterior wall, and in the second example, we can see the accessory appendage is arising from the lateral wall. Now let us see this example. Here we can see this is the left atrium and there is evidence of filling defect in the outpouching suggestive of thrombosis. We need to remember that the accessory appendage, they are not associated with thrombus formation, and the thrombus can occur in the large diverticula of left atrium, but even that phenomena is rare. So this was example of thrombus formation in diverticula of the left atrium. Now here we can see there is this outpouching from the inferior wall of the left atrium. At the cine images, these images are not shown here, the outpouching was non-contractile, and this is an example of left atrial aneurysm. Now the third outpouching are from the interatrial septum. Now these can be either atrial septal aneurysm or atrial septal pouch. So atrial septal aneurysm, these have single wall that can either bulge into the right atrium or the left atrium or both the atria. They are discovered incidentally and can be associated with paradoxical stroke, and they have association with stroke due to coexisting patent foramen ovale, atrial septal defect and the thrombus formation. While the atrial septal pouch have two walls, and the internal contrast attenuation will be similar to the atria from which they are arising, that can be of left atria or right atria, and no contrast material should extend from the pouch into the opposite atrium. They are usually incidentally discovered and they have a controversial association with the stroke. So let us see the images. The first one, here we can see there is this outpouching in the region of fossa ovalis of the interatrial septum. Now for diagnosis of atrial septal aneurysm, we need to see the base and the amplitude. So the base should be more than equal to 15 mm and the amplitude should be more than 10 mm or equal to 10 mm to call it as a atrial septal aneurysm. Now sometimes this atrial septum aneurysm can mimic as a right atrium mass. Like in this example, this is axial cardiac CT angiogram. Here we can see the aneurysm is filled with unenhanced blood from the IVC, and thus it was mimicking like a atrial mass. Now let us see what is atrial septal pouch. Now this is right atrium, this is left atrium, this is the intact normal interatrial septum. Then we have patent foramen ovale. Here we can see there is this long narrow channel that is connecting the right atrium and the left atrium. So it is an example of patent foramen ovale. The next one is example of atrial septal pouch arising from left side. So here we can see this is this channel like opening arising from the left atrium, but the interatrial septum is intact. So this is the atrial septal pouch from the left side. Again in the next image we can see the atrial septal pouch on the right hand side. Here we can see the channel like opening on the right atrium, but again the interatrial septum is intact. So it is example of atrial septal pouch right side. So basically in atrial septal pouch we will see this flap of a tissue. Okay, we will see the flap of tissue. So this basically in atrial septum pouch there will be communication from one atria but not both the atria, in contraindication to the patent foramen ovale and the atrial septal defect. We will see with the image. So the first one is example of patent foramen ovale and the second one is left atrial septal pouch. In both the example we are seeing this flap of tissue which is connecting with the left atrium, but the difference is that in the first images, first side left hand side images, we can see this contrast is passing from left atrium to the right atrium in case of patent foramen ovale, while no such passage of contrast is seen in cases of atrial septal pouch. So this is the differentiating point. In patent foramen ovale, the contrast material will be seen passing into the right atrium as is seen in this example. Now let us see the outpouching from the ventricle. These are basically 4 types: crypt or cleft, diverticulum, aneurysm and the pseudoaneurysm. So let us see. Firstly, the crypt or cleft. This is the diastolic image and these are the systole image. So crypts or cleft are basically slit-like invagination. They are extending more than 50% depth into the myocardium, but they will not protrude beyond the myocardium. And in the systole we are seeing they are completely obliterated and no late gadolinium enhancement will be seen. In diverticula, again we are seeing this outpouching, and in systole we are seeing this outpouching is moving inwards. The wall thickness of the outpouching will be normal, and again there will be no late gadolinium enhancement. The third one is the aneurysm. So here is again the outpouching. Now it can be akinetic or it can expand during the systole. It is having wide neck, that is more than 50% of the aneurysmal diameter, and it is the differentiating point between aneurysm and pseudoaneurysm. As in pseudoaneurysm, there will be narrow neck, that is less than 50% of aneurysal diameter. Both the aneurysm and pseudoaneurysm share some common features, like they can be akinetic or expand during systole, they can have thin walls, and in both cases late gadolinium enhancement will be present, that is suggestive of fibrotic tissue. Okay. Now here we can see in the first image, it is end diastolic MR image. Here we can see the focal outpouching from the left ventricular inferior wall. Now in the systolic image we are seeing this is outpouching is completely collapsed, and in the late gadolinium enhancement we are not seeing any enhancement and thus no fibrotic tissue. So this was example of left ventricular diverticula. Now this diverticula can even arise from the right ventricle. Here we are seeing there is this focal outpouching in the right ventricular wall, that is the muscle line outpouching in the first image, and the second one is late gadolinium enhancement, where we can see there is no late gadolinium enhancement, and thus this was example of right ventricular diverticula. Sometimes we can confuse the right ventricular diverticula with a double chambered right ventricle. So basically double chambered right ventricle, it is an congenital anomaly where we are seeing the thickened bands of the right ventricular, that can either be septomarginal trabeculation, parietal band, moderator band, and it is separating the right ventricular into two chambers, and one of these chambers can simulate an outpouching, especially when it is enlarged. So when these thickened bands are present, they can create a narrow os infundibulum, and it can demonstrate flow acceleration on the cardiac MR images. So whenever we see the severely thickened band which is dividing the two apparent right ventricular chamber, it will be double chambered right ventricular rather than the diverticula. And the treatment for the right ventricular diverticula is not well defined. Some say resection, but sometimes when the right ventricular diverticula is large, these can contribute to right ventricular stroke volume, and in such cases resection is not recommended. So this was example of double chambered right ventricular, where we can see the muscular band is dividing the right ventricular into two chambers. We have learned about the crypts. Here in this example we can see this is the axial cardiac CT angiogram. Here we can see the circumferential left ventricular wall thickening and multiple slit-like invaginations. They are invaginating into the myocardium, in this case from the inferoseptal myocardium. Some say when these are multiple, that is more than two, they are associated with hypertrophic cardiomyopathy, but is not proven, and some even say they can be seen in healthy individuals. So this was example of multiple left ventricular crypts. Now this is axial contrast enhanced cardiac CT. Here we can see there is presence of this wide neck aneurysm that is arising from the left ventricular apical and anterior wall. Okay. Its most common location is the left anterior descending coronary artery territory, and we can easily see the associated myocardial thickening. This is from the pouch, and this is the normal myocardium. Okay, so this is wide neck with thinning of the myocardium, and this was example of left ventricular aneurysm. Again in this example, here we can see this is the left ventricular, and here we can see this is the outpouching from the left ventricular apex. One more thing to see here is that focus on the arrows. Here we can see there is presence of this epicardial fat. Okay, there is this thin epicardial fat layer which is separating the aneurysmal wall from the pericardium. Okay, so this whenever this epicardial fat is present, its significance is that this is example of an aneurysm. Okay, because pericardium will form the lining of the pouch in case of pseudoaneurysm. And in the second image we can see there is presence of this late gadolinium enhancement. So this was example of left ventricular aneurysm. Now this is an example of left ventricular pseudoaneurysm. Here we can see the relatively narrow neck and the wall is formed by the pericardium. Some adjacent hematoma was also seen. There is this sign that is known as the myocardial cutoff sign, which is present in the left ventricular pseudoaneurysm. So we will see in the next slide what is myocardial cutoff sign. So this is example of true aneurysm and the second one is pseudoaneurysm. The grey lining is the myocardium and the black lining is of pericardium. So in the true aneurysm, the myocardium or scar is present in the sac wall. So we will see this smooth tapering at the neck region. While in the pseudoaneurysm, we are seeing there is no myocardium in sac wall and thus there will be abrupt cutoff at the neck region. So this abrupt cutoff is known as the myocardial cutoff sign, which is present in the pseudoaneurysm. Now this myocardial thickness, it is usually measured at 1 to 2 cm from the neck region. Either measure at 1 cm from neck or we can measure it at 2 cm from the neck. Now there is an entity known as arrhythmogenic cardiomyopathy. It is a genetic disorder with fibrous or fibrofatty myocardial scar formation with associated malignant ventricular arrhythmia. Initially called as arrhythmogenic right ventricular cardiomyopathy because it was thought that only the right ventricular was involved. But now cases have been seen which involve the left ventricular also. So radiologically we will see multiple small outpouching from the right ventricular free wall. Let us see the example. Here we can see this is the axial cardiac CT image. Here we can see multiple outpouching are arising from the right ventricular free wall. And these are resembling the bellows of accordion. Hence this is known as the accordion sign. Associated right ventricular dilatation can also be seen in this case. And this is one of the imaging characteristic of arrhythmogenic cardiomyopathy. Now the next thing is transpericardial bulge. So basically when the pericardium is diseased, for example in case of constrictive pericarditis, there will be associated stiffening of the myocardium and it will inhibit the ventricular relaxation during diastole. But this thickening and calcification is not uniform. So there will be spared areas of the pericardium and those areas will result in normal bulge relative to the constricted areas. Now basically the underlying issue is in pericardium and not the myocardium, and hence we use the specific term herniation and not the outpouching. Because this bulge is basically the normal tissue that is bulging, so it will have normal motion, signal intensity and lack of late gadolinium enhancement. Let us see the example. In the first image we will see these are the areas of pericardial thickening and calcification, and this is the normal tissue that is bulging. So this bulge is due to normal tissue, that is the transpericardial hernia or bulge. In the second image, this patient has underwent surgery and was having a pericardial defect, and due to this defect the apical portion of right ventricle, left ventricular and the left atrium descending artery were bulging, and this was again example of transpericardial hernia or the bulge. Now the interventricular septum. Now sometimes when there is small VSD, the leaflet can itself close the VSD and there can be associated development of small aneurysm. Now this aneurysm from interventricular septum can either arise from the membranous part or either from the muscular part. Let us see the example. Like this was example of membranous interventricular septal aneurysm in 25-year-old man. Here we can see the interventricular septal aneurysm in the region of membranous septum. Again, in the second example, we can see the membranous interventricular septal aneurysm. These can be present in the muscular part, and depending on the shape, like in the first image, we call this finger-like muscular IVSA. In the second one, frond-like muscular IVSA, and in third image, globular muscular IVSA, that is interventricular septal aneurysm. Now this is an entity known as the mitral aortic intervalvular fibrosa. Basically, specifically in patients who have undergone aortic wall replacement, sometimes we see an outpouching that is arising from the left ventricular outflow tract. Here in this image we can see this is the left ventricular, and this is the outpouching that is arising from the left ventricular outflow tract, and it is located between the aortic wall and the anterior mitral wall leaflet. So basically the outpouching arising from this specific region is known as the mitral aortic intervalvular fibrosa or fibrous curtain region. Lastly, the Thebesian vein. So these are normal variant. These are basically thin vessel and usually arising from left atrium and directed into the interatrial region. Like from in this example in the image, this is the left atrium and this is the outpouching that is directed from left atrium to the right atrium, and these have a specific tubular configuration and lined by muscular bundle, which is known by the specific name Bachmann bundle. These are imaging characteristic of Thebesian vein, and we need to remember these are normal variants and not pathological. Hope you like the topic, and if you like it, do subscribe and comment. Thank you everyone.